morning, everyone. So this is my first time meeting Sydney, and she's really amazing. And she brings great energy. So I hope I can keep up the energy. I can't promise that. I don't know if I've had enough coffee, but but I really love that, and I think that's really important to have the energy so that we can keep going and keep finding new important treatments for everybody. I'm actually a transplant. I'm not actually from Columbus. I'm from Pittsburgh. So I really appreciate being invited today. It's just a quick 3-hour drive. So this is my first time at the James. So I thank the hosts and everybody for having me today. I have no relevant disclosures today. I just wanted to bring that up. So I think it's kind of important to sort of highlight, I am a medical oncologist, but when part of being academic, at a major cancer center is that we're very multidisciplinary. So we have discussions with our pathologists and our orthopedic oncologists and radiologists and other medical oncologists to really deliver optimal patient care. In, I think it was last year, globally around the world, all these different people, all these different experts met, and they came up with this consensus paper. And I think it's so important. I'm sure many of you already know about it. You should definitely bring it up to your doctors if they don't know. But really, this is so important to sort of define the best clinical approach to treat TGCT. Not only that, but we can sort of try to harmonize our approach. And also we want to, by doing this, we also highlight basically any sort of unmet needs that we find, and it improves the interaction between physicians and their patients, and also talking with the pharmaceutical companies and the regulators like the FDA. So it's also very important that this multidisciplinary team that came up with this consensus did include patients. So I think that's also really important to include the patients. So what are we doing right now? We have a presentation, later on about the surgical approach, and of course this matters, how you sort of approach it based on a nodular or localized type versus diffuse type. But it's also very reasonable to consider active surveillance in patients that are asymptomatic. We do know that surgery is the mainstay, but there's a lot of considerations if surgeries can cause a lot of severe morbidity or even functional limitations. Repeated surgeries are not always the best thing. They can be detrimental. And so I also just want to point out that there is definitely insufficient data to propose radiation. Definitely can be detrimental, especially with a lot of our young patients. So I'm also just kind of pointing that out. So therefore, that's why I'm kind of here, because there's a search for this optimal systemic therapy for patients if we're not going to do more localized approach. So what really makes an optimal systemic therapy? Well, we want to know if the drug is active. And by the way, this is not an exhaustive list. This is just some things I kind of thought of when you're thinking about when you're choosing a drug. So is it active? Does it demonstrate some kind of tumor regression? Because that's a good surrogate marker that it's actually working, right? That the tumor cells are dying. So you can look at this 2-dimensionally, and standardly we use something called the RECIST criteria. This is across oncology, where we're kind of looking at the sum of these lesions. They're called target lesions, and the longest diameter. But as we know in TGCT, and I have a slide coming up, these tumors are sometimes irregularly shaped. So it's also really important to look at more of a 3D or sort of like a tumor volume score to look at the volume of the tumor inside these joint spaces. We also want to see, how long does the activity last? Does it last for 3 months, or does it last for 3 years? Does it demonstrate improvement in symptoms? Patient reported outcomes are really important. Quality of life measures. And then of course we want to know, is it safe? What is the side effect profile? And I think that's really important when we think about giving patients new experimental therapies. And then of course there's other considerations like feasibility, cost effectiveness, and that kind of thing. So as we know, as Sydney reviewed, the hallmark of TGCT is this overexpression of the CSF1. So there is a neoplastic cell that does aberrantly express. So that means aberrantly means it's not really supposed to be doing this. So it expresses the one, and it is most often due to this translocation. So what happens is that when the protein is basically secreted and it comes outside the cell membrane, and then it hits the receptor on the, so it actually has this kind of like vicious cycle where it can propagate its own self by basically attaching to the receptors on the neoplastic cells, but it can also recruit all these other white blood cells, and that creates a big bulk of the tumor. Oh, that was the X for the CSF1R inhibitor coming in here and sort of blocking that interaction that Sydney also reviewed. So imatinib is definitely, so as she mentioned, this is actually not a drug, we call it off-label, but it's actually a drug that we use a lot. I like to say that it has multiple targets. It's kind of like promiscuous, and it basically has all these different receptors. So in that family, so it can target KIT and ABL and PDGFR, and then of course the one that we're interested in, CSF1R. So this is a drug that was approved for a form of chronic leukemia and gastrointestinal stromal tumor, among many others. And so this drug was sort of repurposed, and I kind of highlighted that, I think that there are some more common side effects that people can experience with this drug, and I think that's worth mentioning, especially the fluid, especially around the eyes. It can cause some GI side effects. It can cause fatigue. Almost everything that I give for any type of tumor, sarcoma, etc., can cause fatigue, muscle cramping, rash, even suppression of the bone marrow cells. So that is something that we definitely keep in mind when we prescribe these things. Why did we do this? There actually was a report 15 years ago that basically showed that imatinib in a patient with TGCT, that you can kind of see highlighted here, that after just 10 weeks of therapy, that there was, so here is like basically the tumor cells, and so you can see that they're getting basically thinner here and then almost completely gone at 5 months of this therapy. So that was pretty remarkable. There have been a couple of studies. So in 2012, there was a study sort of published kind of showing that there was some activity. So what you're seeing here is, this is called a waterfall plot. So each bar is an individual patient, and there's this threshold that we sort of had to standardize as what is significant, but this is just a significance in a reduction in tumor size. So we call that a partial response. So once it reaches this 30% basically threshold, then we say, oh, wow, this is a partial response. And if there's a complete reduction in the tumor, you can't even measure it on the scans, and that's called a complete response. And so what we do is we add up the complete responses and the partial responses, and we say that is the complete objective basically total response seen. And in this small study, 19% of patients, so 5 out of 27, experienced one of these responses. We also talk about something called a clinical benefit rate. And so in that case, we say, well, what if someone experienced basically a halt of their tumor growth? Maybe it didn't shrink down, but it didn't grow either. And so we say that might be significant also. And so, and adding those patients that had what we call stable disease, now that 5 went up to 25. So we say 93% of patients actually experienced some sort of clinical benefit. But this is basically just kind of centric to what the tumor was doing. And these studies didn't really dive into what was the patient experiencing. So I think that's something that I'm going to get into. There was also a study published in 2019 kind of looking at the long-term efficacy or the activity of imatinib. This was a global retrospective, so that means they basically found cases of people on imatinib. And there is some bias involved when you do things retrospectively as opposed to prospectively, so I think that's important to highlight. But looking at just 62 patients across 12 different institutions worldwide, and after following these patients for almost 5 years, what they found out was that the objective response rate, so patients that experienced at least a partial response, some of them complete, was about 1/3 of the patients. So we do consider this to be an active drug. Again, it's still considered off-label, but patients did experience symptomatic improvement. was noted, and for the most part, the study highlighted that there was a favorable side effect profile, and it is also generically available. So I think a lot of different countries could get access to it, but I'm not an expert on that kind of access. I know there's a lot of discussions about that in terms of other countries and what we can get access to. So I just have one slide on nilotinib, which is also an oral tyrosine kinase inhibitor that does block many different receptors as well, including the CSF. And this was a phase 2 study that was published, and patients were on the nilotinib oral agent for a year. About 56 patients were enrolled in this study, and 55% of them, so over half of them, continued for 1 year. And at just 3 months of therapy, 92% of the patients did not have any progression in their tumors. And then by 52 weeks, basically about 77%. Now, overall, this is called a Kaplan-Meier curve. So basically, there's little tick marks, and that basically represents a patient that was censored that basically dropped off because of progression or something else. So over time, you start at basically on the left side, you start at the top of 100% of patients, and then over time, you sort of follow them and see how many have not progressed at a certain time point. Now, if I had a waterfall plot here, you would probably not see as many bars dropping down because only 6% of patients experienced an objective response rate, but it was significant, and I think it's important that it could be used as another potential agent for treating TGCT. So then we get into pexidartinib, and this is more potent. So this is something called a kinome, which is a map of these different kinases. And what you can see here is that the concentration of like imatinib of what's actually needed to hit the target, and there's so many different red dots of all the different areas that it hits. Because remember, I told you it was kind of promiscuous. So basically, it takes a lot more to kind of hit that target of the CSF. 1R kinase activity. Whereas with the pexidartinib, you actually need a smaller amount of the medication to sort of hit the target. And so that's why we call it that it's more potent and more specific for CSF1R. So you kind of already have seen this a couple of times now, but this is a schematic that was taken from Dr. Taft's presentation. I have a lot of slides from his presentation in 2018 at ASCO, basically highlighting where the pexidartinib is sort of blocking the CSF1R, and so not allowing the autocrine loop to happen within the neoplastic cells. And so basically the recruitment of the neoplastic cells sort of stops there, and also the recruitment is blocked of basically pulling all those inflammatory cells or those white blood cells as well. And so where this sort of came from is there was actually a phase 1 study that was going on with pexidartinib, and there was a cohort of patients with TGCT, and this is called a swimmer's plot. So we're learning lots of different plots today, but this is kind of neat because it's kind of like swimming lanes. But basically, this plot sort of highlights that 23 patients, so each bar is a patient, that they all had basically disease that was recurrent or was not amenable to surgery. And these patients had a higher dose. They had 1,000 milligrams per day in divided doses orally of pexidartinib. And most of them were on it for a median of about 8 months. And so what we found here was that the response rate was basically half of the patients, so way higher than what imatinib and nilotinib were doing. The little white triangles are kind of like at which time point. So what's on the, oh gosh, I have to go back. So this is the x-axis, y-axis, right? So the x-axis is the time, right? So you know exactly where that patient hit a partial response. You see they're at different time points. They do vary. And so those really exciting phase 1 results prompted the phase 3 trial, the Enliven study. And so to do some really good research, we wanted to make sure that this was a prospective study, that it was global, so it encompassed a lot of different countries, that it was randomized. So, we're not selecting patients with bias. We're kind of using a computer system to sort of select patients to two different groups. And it's double blind. So, the doctors don't know what the patients are receiving and the patients don't know what drug they're receiving. And it's placebo controlled. And so I know that there's sometimes some stigma about this, but, should you get a placebo or not? But I think in a disease like this, I think that actually made a lot of sense. And also, we didn't have really a true standard of care. So I think it's important to try to prove that a drug is active, that you're looking at a group of people that in the experimental group that have an active drug, and then in the other group there's a placebo, which is like a sugar pill, right? To see if there's actually some kind of difference between the two. Basically this study enrolled about 120 patients. Patients were randomized. Like I said, they didn't know they were getting 1,000 milligrams per day initially, and then they switched over to this 800 milligram per day in split doses, and that was in part 1. And then at week 25, they did an assessment, and then in part 2, everybody could enroll into this open label extension. So that was just, I'm sure a lot of you have seen this, but I think it's good review. And so just to go over some of those results from the study that Dr. Tapp presented. So the median age of patients, and you can see between the two groups that what we like to see as scientists is that the groups were some kind of even, right? So there wasn't some large like asymmetry between the two groups essentially. So the median age was younger, and we know that because that's very consistent with our disease population. Most of them were female, also consistent. And most of them did have disease in their knee, but other joints were certainly represented in the study. And a lot of the patients had prior surgeries. Almost all of them had no prior systemic treatment. And many of the patients, over half of the patients, were using a lot of pain medications, probably most of them opioids. So the results sort of showed, so this is our waterfall plot again, and this one looks really nice. So basically what we saw here is by the RECIST criteria, so that's that two-dimensional criteria, when you looked at a time point and they selected week 25, that what they noticed is that 39% of the patients had an objective response, and that included basically 15% that had a complete response. So the tumor that was seen on the MRI scan completely disappeared and dissolved. And this is the pexidartinib arm, and then over here you can see the placebo arm. So there was quite a difference. Now, looking at that three-dimensional sort of view, looking at a tumor volume score, and this is a novel scoring method that was developed for TGCT because, like I said, the linear measurements, the two-dimensional measurements are kind of suboptimally sort of really representing what is actually going on here, because you can see on this MRI, and this is like a sagittal view, like you're taking a slice like this, and you can actually see that if you kind of highlight around the tumor, that it's a very irregular shape. So whereas in by RECIST, this would be 14 centimeters. Here, this is like the volume. So it's really just kind of a better representation. And so what they sort of standardized was that what would be a partial response is if you had 50% or more in the reduction in the tumor volume score versus your baseline. And then if you had greater than 30% a tumor volume score for progressive disease. So by looking at the results by tumor volume score, we see that 56% of patients experienced a response. So that number looked a bit better because now we're sort of highlighting the disease a bit better. And as I mentioned before, I think it's very important to make sure that we have the patient experience when we do clinical trials. So more and more clinical trials are using these patient-reported outcomes. And so they developed a specific physical function, like a PROMIS survey, basically, highlighting that there was a significant difference between the pexidartinib and placebo. So a significant p-value in improvement in function, improvement in range of motion. So there was physical therapists that were actually blinded for the study, and improvement in stiffness. Pain also improved, but that value was actually not statistically significant. So now we get into side effects, because that's all great news, but unfortunately there's a lot of side effects, right? And I'm sure many of you know this. Really common ones, so again, feeling tired, The hair color changes, so having your hair turn white when you're 25, or any age really, right? And then developing liver problems, a liver injury, changes in your taste, nausea, vomiting, headaches, and swelling around the eyes. So I think what really worried, and all of them are significant, but what really worried many people is that the liver dysfunction. So 8 patients actually discontinued the treatment because there were changes in liver function, and 4 of these were serious but non-fatal events, where the bilirubin, which is a measure of liver function, improved. In that one patient, it lasted 7 months until it actually returned to normal. So most of these, well, almost actually all of them happened in the first 2 months of treatment. And I think that's important so that basically physicians know when to look out for it. And so we also noticed here that in the higher dose of pexidartinib that this was occurring a lot more. So it was like a dose dependent sort of side effect, that when you were taking the patients in the crossover arm, it took less, there was less occurrence of these liver dysfunction. So even outside of the TGCT study, there were unfortunately 2 patients that actually succumbed to death because of the medication. One was, one that died that was also getting the higher dose, but also had an advancing malignancy. But one patient required a liver transplant. So these were not taken lightly, very, very seriously. And again, this all occurred in the first 2 months of treatment. So I will get to that in a second. But just to quickly conclude that this drug was felt to be very active and ultimately in 2019 got approved. So this was our first approval for TGCT, an oral therapy. And then quickly, some long-term efficacy results that were then published the following year, kind of showing that this is by RECIST, this waterfall plot, that now that objective response from 30-something% went up to over half of the patients. So the longer you stay on this, there's actually patients who are achieving response later on. So, and then by tumor volume score, additionally, that number also increased. So I just wanted to share a quick case of a 23-year-old female who was on it. I do recognize that these are not like exact slices, but the MRIs were taken at different times, about 5 months apart. But this is a patient who was on 400 twice daily of therapy. That was the originally approved dosage of pexidartinib. But these little blue stars sort of highlight that there's effusions and a huge tumor mass in this MRI. This is a knee joint, and it's taken sagittally. So that's like a slice like this. And so on this one picture on the right, you can see the effusion is gone and that big tumor bulk mass is almost completely gone, just in this slice. But major dramatic improvement. And this female was very excited because she could wear high heels again, because she had not been able to do that. And she was just so excited to do that, among other things. So very important considerations as I wrap up here. Again, the liver toxicity. So when this got approved by the FDA, it was very important to consider the REMS program. And then I also wanted to touch upon the dietary restrictions or the food effect. So really safety first. And so every prescriber that prescribes Turalio has to register with the risk evaluation and mitigation strategy. And patients have to also agree to this, so that you're getting your blood work done every week, for the first 8 weeks. It's very, very important, because during this time period is where we see all of the liver function events. So I think that was a very smart move to basically implicate this moving forward. And then, of course, this past year, earlier this year, they changed the dosage. So there was a lot of sort of research going on with this liver toxicity and the food effect. And if you basically, your absorption of the medication is affected by your food, right? So basically what happened was that the dosage changed. So now we're doing 250 milligrams twice a day with a low-fat meal. So it's a lower dosage, but you're actually taking it. And so what our Daiichi Sankyo sort of came up with was some examples of like what could be the fat content in some of these common foods, just to help patients, because obviously that's a lot of extra work. So it's interesting that that's how you started basically your talk of like, would you alter your diet to take a medication? It's a big deal. So anyway, my segue is kind of like looking at next steps. So what is the optimal duration? Could you discontinue pexidartinib if you've been on it for a long time and doing really well? I think that's not yet established, but I think there's a shared decision making. We can talk about this maybe in the roundtable as well. But I think that you can continue as long as per the patient's symptoms and desires. Perhaps if you had complete resolution of symptoms, you could consider stopping treatment and maybe a re-challenge in case of progression. So I think these are just some thoughts. And then, of course, we're looking forward to some more potent inhibitors, even more of CSF1R with more favorable toxicity profiles and other things. So I'm looking forward to the next presentations, kind of reviewing what's to come. And then this is just a quick table of what the drugs that I sort of highlighted from the consensus paper of basically a summary that, with imatinib and nilotinib, you're looking at, lower response rates. And with the pexidartinib, you're looking at much higher response rates for patients and much more durable. So that is all I have for today. I apologize if I talked way too quickly, but please let me know if you have any questions. And there you go.
Yeah, any questions for Dr.
Yes.
We'll have plenty for the roundtable. Yes. Yeah.
Real quick, I just wanted to understand the fat content thing again.
Yeah.
Is it that you shouldn't have the fatty foods then, and that contributes to
Right.
better and
So really high fat content meals will actually increase the absorption, so it actually could worsen the side effect profile. So that's why you have to make sure that it's a lower fat content so that it's only being absorbed at that certain amount.
So it's 11 to 14 grams
Yeah.
of fat when you're taking the drug. It's not at all. So you can go 6 hours later and go have a fatty meal. That's fine. But it's when you take the drug, it helps the actual absorption of it in your gut.
and then does that minimize the effects on the liver then as well?
That was the idea.
Because you have less free drug, right? You're absorbing more. The drug that's actually in your body is actually doing what it's supposed to. You don't have extra drug everywhere. And people who were on it before were on an empty stomach. So if they happened to eat, they didn't follow the rules, they would spike their amount. So it's also, it was multifactorial in life.
Yeah.
Thank you.
Sure.
Quick question. Is there a decision tree that doctors use to reduce the dose? So that,
That's a great question.
Some people when we're out for practice say, oh, I'm on half a dose, I'm on a 3/4 dose, I'm on a full dose.
Yeah.
And what decision tree criteria need to be met?
Yeah.
If you're taking less is more, that you can move down to the next.
Right. That's a great question. I mean, yeah. So ultimately, as a physician, on a clinical trial, there's very strict criteria. I just want to point that out, that we have to follow a protocol because that is what's important for keeping patients safe. Once a drug gets approved, there is some discretion that a physician can have. And I think that's why physicians continue to be educated, right? And to go to talks, and stuff like that too, to learn how others do that. But yes, there are some suggestions like in the package insert about what to do in terms of, if there's like, for example, with the liver toxicity, if there's a certain criteria level that you would reduce the first dose reduction and the second dose reduction. So it's a discussion and there are some guidelines.